Right, welcome if you're just joining us. My name is Boy, and we want to have a quick conversation on matters concerning our mothers here in Kenya today on Health Tuesday. I know Ram runs this segment, but today is all about my ladies, and I am here to take charge. So we would just quickly want to talk about maternal health care and just see where we stand, how the situation is on ground, and what more we need to do to just try and prevent maternal death, the maternal mortality rates that we have been experiencing here in Kenya. And just looking at, countries like Finland, we have Greece, we have Iceland and Poland. Looking at the mortality death rates, it is currently at 3 out of every 100,000 births. 3 women succumb to birth-related complications out of every 100,000 births. This is some of the countries that have the lowest mortality rates when it comes to our mothers. But where do we stand here in Kenya? We've just run for you a very short feature that was done. It's much longer than that, but you can always catch it on our website or go to our YouTube channel, KBC Television. You'll be able to catch the full feature and just try to understand what it really is about. But I have 2 fantastic ladies here with me on set to help us better understand the situation on ground and what they are doing to just try and help the situation and some of the local inventions that have come up just to be able to help better protect our mothers. To the extreme left, we have Doreen Awino, who is the Community Health Systems Director working with Luala Community Alliance. Karibu sana.
Thank you so much.
Very glad to have you.
Pleasure.
And to my immediate left, we have Dr. Joyce Wangari, who is a general practitioner working at the Migori Referral Hospital. Karibu sana.
Thank you.
Glad to have both of you with us this morning. So if you have any questions or any comments in relation to maternal health care, please feel free to send them through. Our hashtag on Twitter is Good Morning Kenya. Our official station handle ever remains at KBC Television. My handle is Boy. My colleagues at Ramaguko and at Raymanyara. And of course, our SMS line is up and running. 20154 is the number. Shoot those questions. Anything related to maternal health care, we'd be absolutely glad to help you better understand what more you need to do. If you have a lady who has just given birth recently and you're trying to understand how you can go about in helping her recover, please send any questions or any clarifications that you may be needing and leave a name and location. We'd love to address you by your name. Now, let's just start with the basics. When you talk about maternal health care, maybe somebody's wondering, okay, what does that even entail? And let me start with you, Joyce. When you talk about maternal health care, just give us a general and a very brief explanation of what maternal health care is all about.
Maternal health care is all about health care during pregnancy, childbirth, and the period immediately after childbirth, up to 6 weeks.
Up to 6 weeks postpartum.
Yeah, postpartum.
All right. Yeah. That is the time in which most complications tend to come up.
Yeah.
During childbirth.
During pregnancy, childbirth,
and 6 weeks post. All right. So we'll be talking about some of the complications that come as a result of childbirth. And let me come to you, Doreen. You work with the Luala Community Alliance, which is doing such fantastic work in Migori. Maybe you could tell us a bit about what Luala Community Alliance is even what it's about.
Okay. Luala Community Alliance, we call ourselves community-led innovators. And we are looking at a community health-led model where we have got the community committees who actually kind of plan the activities, look at the issues around the community, and then look at what are the solutions available. We look at the community health workers or health workforce, where we quickly recruit community health workers, we train them, and of course over time monitor them and help them to work with them to collect issues of the community, and of course that the link between the facilities and the community. Then we are looking at the health centers or health facilities, where we're working closely. Luala itself is a health facility, but we're also working with other government facilities, so that looking at the work in terms of service delivery. Then we're also looking at data collection, integrity, analysis, and use. So our health model has got those 4 kind of pillars. I know our mission as well is actually to look at to facilitate or capacity build community members to take on their own health. Yeah. All
right, so let me come to you, Joyce. When you talk about maternal death rate, what is the situation on ground in Migori? You've been working there for a while, so maybe you could tell us a bit about how the situation is on ground.
Migori County is one of the highest has one of the highest maternal mortality rates in Kenya, among other 15 counties in the country. And currently we are at 673 maternal deaths per 100,000 live births, which is a very huge number. Migori and about 15 other counties contribute to 60% of the Kenya's maternal mortality rate. So the current country's Kenya maternal rate is at 362 per 100,000 live births.
All right. And Luala, the Luala Community Alliance has taken up, maternal health care as one of the integral projects that you guys are really pushing. Why did you choose to go with maternal health care? Among the many other issues that could be on ground, but why maternal health care?
Okay, one of the things is that looking at, maternal health care, the mothers are the ones actually who produce. And also looking at, from what Doctor has said, the high maternal deaths, and we should not be losing any mother while giving birth. So looking at all our activities, this is one of the major programs that actually we are really running into. Apart from just that, there are others also, but this one was major because of child deaths and maternal deaths. But now looking at it from that, the mother is giving birth to a child. Why should she die during delivery?
During delivery, which will be such a beautiful moment. Some cases turn to be the other situation. And one would be wondering, just even looking at the communities at large in terms of being aware of what maternal health care is all about. How are the awareness level and civic education among the people when it comes to maternal health care in Migori? Are the people as, do they know what maternal health care really is all about, as opposed to what is expected, you are expected to know, but the situation on ground? Do our young mothers, especially our young mothers, do really understand maternal health care in Migori County?
I'll start by saying Migori County has one of the highest adolescent mothers. Like 1 in every 10, 15 to 19 mother is giving birth in Migori County. And it also has one of the highest fertility rates. It's at 5.3 and the country's is at 3.7, I think. So they are really working hard at getting pregnant. And I'll say right now the awareness about maternal health care at the hospital level is much better than it was a few years back, where they had embraced the culture of traditional birth attendants. And you'll find a mother who'd given, she's had like about over 5 pregnancies, and 4 of those were delivered at home. So it's very hard for her to break that practice and come to a hospital. But with the advent of the free maternity care, we've had an increase of people coming to hospital births. Yes,
Doreen.
And you talked about awareness at the community levels and people take it. Okay, from our side, look at, we're working very closely with the community health workers who are actually members of the community. So by actually identifying them and training them, we give them skills in actually maternal health care, looking at it all the way from pregnancy, how do we take care of the women during antenatal care? And this don't just go to the mothers alone, it goes to the community as a whole. Because during the community reviews, during the home visits and all that, they do that work. Then we also give them information about delivery and how preparing for birth and actual delivery, so they should go to the health facilities. And after that also, why taking care of the mother and all that. So there's that kind of awareness done in all the community structures, using mostly the community health workers.
And it's effective in terms of instilling knowledge in our young mothers and just letting them know the basics of what you need to do in the event that you're not close enough to a hospital or to a medical practitioner. It is working. It
is working so well because during those community interactions, there are the answer and questions, the question and answer sessions, where even the issues of myths, misconceptions, some, challenges, HIV/AIDS and all those things that are tackled during that time. So there's more awareness and more information given so that somebody makes informed choice.
Yes, because that's what we're hoping, you make informed decisions. Now, you've mentioned the whole aspect of, free maternal health care, which came into effect, from the 1st of June 2013. I did come across an article that actually indicated that, more women are having hospital-based births. But when it comes to the mortality rate, is the number a reflection of what we are seeing in terms of the number of ladies giving birth in hospital. Has it helped in bringing down the number of mortality cases that we have been witnessing from your interaction with our ladies on ground and even other practitioners?
I feel it has. What I will say we are yet to achieve is getting high numbers of mothers coming for focused antenatal care, where we are able to do a risk assessment right from the prenatal period and categorize them and tell them you have a potential risk, you need to deliver in this facility, in such a level of a facility where in case of anything happens, emergency care is there at the go. So I feel we need to do more on the antenatal care aspect.
All right. Now, so Doreen, do you think with the advent of free maternity care, this idea could just bring down the numbers of mortality, the mortality rates that we've been seeing here in the country?
Okay, I can say yes in a way, but also there are the different things at the community level. There are the different delays that we experience. Somebody has the information, but like delay in actual just decision to
execution,
to seek care, and then also reaching the facility level, the actual services. So as much as that is taking effect, but in terms of this knowledge, we'll have to keep on pumping and making more awareness and making people understand at different levels. Because we don't want any mother to die, of course. So I think that is okay, but the community level
proactivity is still wanting.
Still wanting. And making proper use of the community or working together with the community health workers is a key thing, which we really need to embrace. Not just as Migori as a country.
All right.
Just to add on that, you'll find that this free maternity thing has made some of our patients very lax. They won't attend any of the antenatal visits. They'll just appear at the hospital because it's free to deliver. So when you do the pre-delivery test, you find she's already a high-risk mother, and she already has coexisting complications. So that's one of the disadvantages of the free maternity. So I think enforcing the focused antenatal care plus free maternity will help prevent everything.
Proactivity still needs to come into play, especially from our mother's side. Now let us quickly look at some of the causes of maternal mortality that have been such a problem here in the country since time immemorial. And the first one that always comes to mind is hemorrhage. Tell us a bit about that for the benefit of our viewer, to just help them understand what it is in the first place and how it is a cause of death.
Okay, obstetric hemorrhage has been and still is the number one killer, the number one maternal mortality cause of death. And the obstetric hemorrhage you're talking about is a postpartum hemorrhage, excessive bleeding after delivery. That's where most of the deaths happen. But we also have antepartum hemorrhage, which is hemorrhage before delivery, but after 20 weeks of gestation. And there's also early pregnancy hemorrhage, like first trimester bleeding, the abortions, and the ectopic pregnancies. So all that encompasses obstetric hemorrhage. And why hemorrhage is a killer is because without fast action, the mother will quickly go into hypovolemic shock, where the organs are deprived of oxygen, and it leads to organ failure and eventually death. So,
all right. And maybe what are some of the causes that lead to this excessive bleeding? What are some of those predisposing factors that actually put you at risk of hemorrhage after delivery?
So we have the women who've given birth multiple times, the multiparous women, the above 5 pregnancies, the ones who are coming at this is the 10th or 7th pregnancy.
That's a risk factor.
That's a risk factor. And the ones who've had a previous history in a previous delivery, they had hemorrhage after delivery, they're also a risk factor. And the ones who have multiple pregnancy, twin pregnancies, and we have the ones who've had prolonged labor. They've been in labor for over 24 hours, and they're
that's
risk
also
of
a risk factor.
PPH.
All right. Doreen, do you, from your interaction with your community, do they really understand what this hemorrhage is, or it's just taken casually among the women that you have interacted with?
Most women maybe let's say in the last few years before active intervention, the community health workers, they did not kind of really understand. But now, being that is one of the leading causes of death, we are actually putting a lot of emphasis to empower those who interact with the community members, the community committees, the community health workers. So that now, during the interactions with the women during antenatal care, they're actually taught or given information about danger signs and some things that can lead to such kind of the hemorrhage that the doctor is talking about, and any other danger signs during pregnancy.
Yeah.
But this is kind of emphasized each time for them to understand. Because, you know, some people just say, okay, you know, it was just some minor bleeding, and then assumes, then it's like it disappeared, then it comes back. So it's like it's a normal thing. I'm told it's normal. But you know, when you give information now that such kind of bleeding, don't just take it for granted. Can you seek for help? So that you are examined and you are told the correct situation or something is done in time. Because one thing is that the late interventions is what actually now makes the intervention is not successful, because somebody delays, comes in last minute, and you can really do nothing much.
Now let's quickly look at another aspect, and you know, it's just also just sampling from other cases that we saw then, that is ectopic pregnancies, and just help our viewers understand, you know, what ectopic pregnancies are, and you know, the risk that comes with ectopic pregnancies, because from just what we have seen, this lady had no idea she had an ectopic pregnancy until one of the tubes ruptured. But maybe you can just tell us from a medical point of view what an ectopic pregnancy is and how it comes about.
An ectopic pregnancy is a pregnancy which is in other places other than the fundus of the uterus. So most commonly it's usually in the fallopian tubes, but it can also be at the where the ovaries are, or it can also be abdominal. So how it comes about is very technical to explain, but
in layman's language,
but it's an arrest of progression of the fertilized egg into the uterus. So it gets attached there and it starts growing at the fallopian tube, and eventually at around 8 weeks, that's when it ruptures, because it's run out of space. So when it ruptures,
what are the consequences of a ruptured fallopian tube?
Hemorrhage, internal bleeding. So a mother will experience pain either on either side, or she'll come unconscious when she's already in shock. She'll have a history of amenorrhea, no periods. So when you do a pregnancy test, it's positive. So those are some of the key signs we look out for when we have an ectopic pregnancy.
All right. And once the tube has ruptured, does the bleeding start to come out immediately, or it's very hard to be detected?
It depends on the extent.
With the pain.
It's very hard to. The pain is not a marker of an indicator of how much she's bleeding. It can be a slow leak, or depending on the extent.
So it's very silent.
Sometimes it can be, and other times it can be overt.
All right. Now, Doreen, maybe from even interaction with the people, what are some of the misconceptions about, you know, ectopic pregnancies have you come across from the community and their understanding of an ectopic pregnancy?
Okay, looking at the issues of cultures and myths, like now, you know, you did something wrong for the child not to be in the right place. So that is something which is there, but of course, I think over time people are getting to understand some of these things. And this particular case, like for me, it's very interesting because she didn't know about it, as you rightly mentioned. Then it ruptured, and then she got into shock at home. The husband brought her in. And you know, this woman, when she came to the facility, she was like already into shock, and the husband was like, please just see if you can revive her back to life. It's like the woman was really dead to her. And then of course, when she reached the facility, the interventions, putting on the nurse garment and all that, she was like, now we saved her from death in the first time. But her story is a long one, because we transferred her to Homa Bay with the nurse garment on. But in Homa Bay, the nurses who are receiving the patient, they had no idea about the use of the nurse garment. So during the preparation, and she was to go to theater for operation, they actually removed the nurse garment. And there she was again dying, like in quotes, a second time. They ran away and were like, the woman is dead again. But good luck, she was accompanied by a nurse from Olwala who knows about the nurse garment. So she had just stepped out briefly to just sign some notes at the OPD. So coming back, like, what have you guys done? She quickly reapplied back the nurse garment, and then within 5-10 minutes, again she was back.
Right.
That is when actually when we decided now to work with Homa Bay team to let them know about the nurse garment, because like this woman was escaping death twice.
And we'll be telling you a bit about this nurse garment and what it has done in Luala. But let's quickly look at some other, causes of maternal death. Another one is infections that come post-delivery. And, so the post-delivery care is very, in most cases, it's left to the mother, and you are there trying to take care of yourself, trying to take care of the newborn. If you have other children and a big family, also trying to take care of that. So you don't give as much attention to yourself when it comes to your care postpartum. And infections are also another risk factor when it comes to the causes of maternal. Maybe tell us a bit about that.
Yeah, puerperal sepsis is also one of those killers. It's, I think, number 3 after obstetric hemorrhage, hypertensive disorders, and then puerperal sepsis. That is infection after delivery. Most times it's usually also preventable, because most mothers, as I've seen in Migori, they are very big users of herbs. So they'll have tried to use herbs to induce labor. Or
to induce labor?
Yes. And herbs also for wound care. They are big believers on herb use. So some of that predisposes them to infection to both the mother and the child. And also other aspects of infection is aseptic, not carrying out aseptic procedures, or even prolonged labor can predispose to puerperal sepsis.
All right. Now, Doreen, do you think our mothers, are at a point where, with the knowledge that has come in regards to maternal care postpartum, they're at a point where they're actually willing to go this medical way as opposed to, the traditional mitishamba, the traditional herbs, as opposed to that? Where do we stand from your interaction with our young mothers especially?
Okay, I can say in the areas where we have got interventions and active community participation and dialogues and that, there's that bit of understanding. But where we've got kind of limited interaction with the community, those things are still way there. The use of herbs, the use of traditional birth attendants who are not trained, and just using anything, including even religion. So some of these things where there's no active intervention and working the communities closely to have those dialogues to explain some of these things.
It's still a problem.
It is still a problem. Though at least I think we've made in a bit of steps with working the community health workers, because some of these things, they meet and frequently talk about it.
The more you interact, the more they're able to better understand and take on this new direction.
So it's still there, but we are making progressive steps.
We're making progress. And we'd rather those baby steps as opposed to nothing. Now, you had mentioned hypertension as another cause of maternal death. And for some, you never know you actually have high blood pressure until you pass out somewhere or it manifests. Tell us a bit about, at what stage, hypertension tends to pronounce itself during the pregnancy, the gestation period.
I want to say it doesn't choose a time.
It doesn't?
It
depends
choose
with anyone.
a time, but there are those people who are at risk of hypertension. There are those who already have high blood pressure before they get pregnant, so they will obviously be hypertensive when they get pregnant. And also the extremes of age are at risk of being hypertensive. They're really young, they get what we call preeclampsia, that's hypertension in pregnancy. And then this brings us back to focused antenatal care, because it's part of the screening for hypertension is part of the focused antenatal care, using urinalysis and also actually just measuring their BPs so that you can categorize them according to the risk of the BPs, of their blood pressures.
So it's very important to actually go for these antenatal clinics. In as much as you feel it's just a formality, some of these things just require that random visit, that one visit, to be able to detect and help avert a crisis. And especially with pregnancy, they say pregnancy is that walking that thin line between life and death for any mother, So is childbirth. So if you know somebody who is expectant and they're not going for their antenatal clinics, please encourage them to go for these clinics. They will help so much to avert situations that could lead to things that we wouldn't want to happen. All right. Now let me quickly come to you, Doreen, and I'd like for you to just tell us a bit about another cause of maternal mortality, especially among our young girls, is unsafe abortions, and that has been on a constant rise across the country. We see our young girls are dying, and when you hear the situation, an unsafe abortion. Tell us a bit about your interaction with unsafe abortions in your community, and even from your interaction with our young girls across the board.
Yeah, it's actually a situation which is worrying because one, the many pregnancies occurring during teenage age. So there are very many. These young girls, like they want to continue with school, but here they're pregnant. Some of them are already, you're abandoned by the family or the boyfriend or whoever made her pregnant, abandoning. So the only thing she has to resort to is to abortion. So these cases are actually there, and it's a trend which I think we really need to take it up, not just the health sector, but collectively. Yeah, because they resort to unsafe abortions because they want to continue their lives. They don't want to be abandoned. They want to go back to school. They want to be accepted. And I'm pregnant, I have a child, it's like you are now a woman and neglected. So all these things running in the adolescent's mind, the only thing she's seeing as a solution is to go for unsafe abortion. And this one leads to very many complications that we've already talked about. Yeah, so the trend is still there. It is still a big problem, and we just have to step up as medical practitioners and the community and all the stakeholders to look at what do we do to support our young girls from having early pregnancies or unplanned pregnancies
and resulting
into unsafe abortions. Yeah, because it's something which is still a big worry.
A very big problem.
It is, yeah.
And at this point, just to let you know, we are not advocating for abortion. We just want to talk about a reality that is on the ground, and that is unsafe abortions. It is happening. And mind you, abortion is illegal. All right, it is illegal here in Kenya. But let me hear from you, Doctor. In regards to unsafe abortions, just what are some of the consequences that you have actually seen, at the hospital as a result of these unsafe measures that our young girls tend to turn to?
The worst I've seen is she came with a pelvic abscess. That is, she tried something and then she developed an infection that later she had pus collection in the pelvic area, and she had multiple, we had to open her up multiple times, like up to 3 times, to try and wash out the abdomen. Yeah, and she was this close to losing her uterus, so yeah, but she was lucky. So those are some of the consequences of unsafe abortion.
And they can actually lead to a lady being barren, because in some cases even the uterus has to be removed.
Even she's still at risk of being barren because of the healing with fibrosis and PID later in life. So yeah.
It's such a big problem. And just take a minute to just talk to our parents. We're still in a society where we don't talk about sexual education with our children. In as much as times are changing, we are becoming more relaxed when it comes to talking about sexual education with our children, but we are not yet there. So you tend to find our young teenagers tend to find out all these matters to do with their sexuality on their own, and they find themselves in this situation. Maybe just your word of advice to our parents when it comes to talking to our children about these things from home, so that when they get out there, they know what to do.
I like to tell them to accept reality. Statistics have been done. The children are engaging in sexual activity from as young as 9 years old. So they'll have to have this talk early, and they'll have to be very open about it. If they can't, maybe just form groups where someone can come and give the talks, and also review what is sex education at school. What are they teaching? Because there should be a difference if they're being taught at school.
You should be able to see
something.
Doreen, also just when it comes to being open with our children about their sexuality, because we tend to be reactive as opposed to proactive about it. Your word of encouragement to our parents.
Okay, I think one thing is that definitely prevention is better than cure in any circumstance. And of course, these early talks and, trying to understand, being close to our children and understanding them. Looking at the growth changes, like when they start having moving from childhood to adolescent. So we should have these talks and, be very close to our children to understand, and we give them the right information. If we don't have them as parents, we can work with the different agencies who are there to, telling teaching us how we should take care of these children. So that now when they get into their peers, they're able to, detect and know this one is actually leading me wrong, this one is giving me a right direction. And then, of course, encourage a lot of peer education that is focused so that now, they support each other as peers.
Yes.
So parents have got a role, but also as practitioners and community, let us also embrace this bit of educating them for peer education so that now they actually support each other and counsel each other and, warn each other and all that.
And what your child doesn't learn from you, they will learn from somebody else. So it's better they learn from you. You're able to control the situation in some way, as opposed to let them learning from somebody out there who you have no idea how they went about in teaching your children these things or how your children learned from them. So talk to your kids. Talk to your kids. Talk with, not at your kids. Talk with your children. Don't just be there dishing out orders here and there. Don't do this, don't do that. Explain the why to them. And then you empower your child from a very young age. They become independent and they know how to handle themselves in such situations. Now, we just want to move the conversation along and look at how we can help bring down maternal death rates here in Kenya. And just from what you guys are doing down there in Luala, it's such a fantastic idea. We've been mentioning this NASG, but someone is wondering now, what is this NASG? Who is this NASG? Because is it Nas Grace, Nas someone? But NASG is actually a device of sorts. Maybe tell us a bit about it, Doreen. What is this NASG even in the first place before we get to understand the story behind it?
So NASG is non-pneumatic anti-shock garment. So
it's an acronym.
It's an acronym, yes. And it is a device that is actually applied on the lower extremities. What it does is that the way the material is made, that is like more a kind of a stretchy. So when it is applied at the lower extremities up to the abdomen, it actually helps in okay, let me say when somebody is already bleeding and losing a lot of blood and of course going into shock. So when the device is applied, it actually limits the blood flow to the lower extremities where you don't have the vital organs. So by limiting blood to the lower extremities, we'll give in room for more blood volume to come to the vital organs. We have the heart, the lungs and all that. So that now, when the vital organs are actually active, then you get that now this woman can actually be sustained. So it is actually a first aid, more of a first aid device. Because looking at the application, which is very easy, and anybody can apply as long as she's been taught, and can help this mother now to, because after application, it kind of like reverses the shock and lowers the extent of bleeding. And we're going to be running something concurrently as we go on with this interview for you to just understand what this device is, and that's actually it on your screen. That it's the green device under the lady's legs. It's a garment, so that's how it is being administered, or rather put on the lady to just try and limit blood circulation to the lower limbs and help, redirect blood flow to the to the torso. So to also avoid blood loss, that is as a result. Now, Joy, your first interaction with this garment, what was your immediate reaction to it? Was it something that you actually was skeptical about, as a medic? What was your first interaction with this garment?
I actually don't remember, because my first interaction with the garment was, the woman was already in shock. My primary focus was getting her back. So whatever could get her back, I wanted. So the garments, UBT, uterotonics, everything. So whatever works.
Whatever works. Yes, and maybe Doreen, you can tell us a bit about, how you even got to a point that this garment came into play. What's the story behind this garment?
Okay, as Luala, as I mentioned earlier, we call ourselves community-led innovators, and we partnered with the University of San Francisco, who already had knowledge about it.
Yes.
And in our quest for looking for innovative solutions to support our mothers, then after partnering with them, then now they introduced the nurse garment. We got to know how it worked, and then we of course got the garments and did the first training in Migori County. So our interaction with the University of San Francisco already have use in Tanzania and other countries. But of course in Kenya, I think it is the first.
You guys are the ones who actually have it.
Yeah.
Just, going to Homa Bay was a whole different story.
Yeah.
Now, your interaction with the community with this, this garment, how were they towards it in terms of unapata umefungwa miguu watu nashinda hii ni uchawi gani? What is this? How was the interaction with the community, especially when it came to administering this at the hospitals? Let me hear from you first, Joy. When you found a lady who needed this garment on and you had to administer it on her, how was it when you were just trying to let them know that this is supposed to help you, but they don't understand?
As you said, most times they are restless and a bit confused.
Yeah.
So at that point, you have to engage with a relative and tell her we are losing blood at a high rate and we need to do
Seeking consent.
Yes.
Yeah.
So as you're applying it, you're also explaining what it's doing. And at that time, because they've seen the state their patient is in, they're like, just do it. Yeah.
Yes, Doreen, when you first introduced this garment and you're trying to tell the community what it's about, how was that process?
Okay, I know the first time we used the garment, it was a night, and we had actually to explain. Okay, the lady already had passed, had like gone into shock, so we had to explain to the relative that this garment is actually just a garment, and just going to help to reduce
blood loss.
Yeah. And that point in time, she's also desperate to see the client come out of shock.
Yeah.
So there was no resistance.
Fanya, can you
we want her safe and alive. So you just do your thing, just do whatever you have to do to make her alive. We haven't met any resistance on the use of NASG because I think it's the process of, explaining how it works. Because when during application, when the woman recovers from shock, we're able to ask, how are you feeling? Do you feel some pain? We applied this on you because of ABCD, and she's able to understand. So that we haven't met any resistance, or like one guy was calling it a bladder, but it's okay
because of its elastic nature.
Because of elastic nature. But because of the results, then it's really accepted because she was in shock, she's out of shock. No, it's like a miracle worker. So there's no resistance as such as that.
All right. And maybe how long does this garment take to just, sort of reverse the effects of that come with shock? Joy?
We've seen effects of the NASG after application from 2 to 5 minutes. Someone comes out of, they were unconscious, then they become conscious.
Yeah.
Nice. Yeah. I'd like to see that in person, but such results are what we're hoping to see because it would bring down other risks that are associated with, hemorrhage. Now, when it comes to the training of this garment, there are very few people, as you just told us that, you learned of this garment from abroad, came here, tried to apply it, but not so many people know about it. It's just even your community that is aware about it. Going to Homa Bay, it was a situation. When it comes to the training as to how to use this garment, because, if you don't use it properly, it won't be as effective. Where do we stand when it comes to the training of our nurses and our doctors at the hospitals?
Okay, so far, maybe from what we've done so far, we've already trained, 2018, we trained 189 nurses and doctors in Migori County, including the few we trained in Homa Bay. And this year, we've again trained additional 32, just in July. And then, once we train them, they also keep on training the others because the training actually is just a two-day training. It's a very simple training because just the application, understanding how to apply it, how it works, and then of course the removal, which is the most important bit. And then after the removal, there's a bit of cleaning, quality and infection prevention, the bit of cleaning and storage. Because one NASG can be used 100 times.
Up to 100 times?
Up to 100 times.
One garment.
With proper usage and cleaning and storage.
All right.
So once we train people, which are a two-day training, there's a lot of simulation and demonstration because actually understanding the concept is very easy. You can take 30 minutes to understand. Application also can take very few minutes. So just practice now, because sometimes when the woman is shocked, sometimes you tend to panic because you don't know the next thing. But when you regularly practice application and removal, then it's something which it's like a norm. It becomes a norm.
Becomes natural. You.
So once you've trained people, and you can train anybody, including the ambulance drivers, the community health workers, because anybody can apply it. So long as she knows how to the different segments. There's a training guide and even a chart which can show, you can be pinned on the wall to show somebody how to apply, where you start from, what you check on. There are those posters that we put in the facilities to guide anybody.
All right. Now, this NASG garment is meant to help our mothers, but you find there may be those ladies who might be at risk when, this garment is used on them. Now, maybe we can hear from you, Joy. Are there those, contraindications that come with this garment for some mothers who might be needing it but are not allowed to get this garment put on them?
The NASG garment cannot be used on a mother with a viable fetus unless she's at risk, both her and the fetus are at risk of dying. Then the application of the NASG garment trumps the risk of
so when you're still at pregnancy, you cannot have this garment administered?
No, you can use it during antepartum hemorrhage, like in ectopic pregnancies, or the bleeding that comes after abortion. You can use it then. But in advanced pregnancy and the fetus is viable and the mother is not at risk of death, don't use the NASG garment. Look for an alternative method of dealing with the bleeding. But if the mother's life is at risk, then the mother's life trumps that of the child. That's the rule, unfortunately.
Save the mother.
Save the mother, So then we can use the NASG garment. Also, we can't use the NASG garment when there are torso injuries, like there's a chest injury or there's an abdominal injury. You can't use it then.
So those are just basically the only conditions that you will limit the use of NASG.
Or if there's bleeding above the abdomen, in the thorax and above, you can't use the NASG garment.
Because when you redirect blood, it leads to excessive
bleeding.
It will.
Exactly.
All right. And maybe somebody is wondering also. Yes, you have put it on, and I know how to put it on, but at what point does it have to come off? Because excessively will also lead to other problems. Maybe you could tell us a bit about that, Doreen, from your interaction with, when you're training, and for somebody out there who might be having access to this garment, but they don't know how to go about. They know how to apply it, but when it comes to removing it, what's the process like?
Okay, one is that vital signs of the woman are taken.
It has to be at the hospital, first of all.
No, application.
Preferably? No,
removal. Yes, removal has to be at the hospital.
Yes.
Or by a skilled person who knows about the NASG.
So one is that once the NASG has been applied and all interventions done, and the woman has been stable for at least 2 hours, then now you start the removal process. And as you remove it, you start with the lower segments, and you take the vital signs. Remove the first segment, wait for 15 minutes, step by step until the whole thing. You keep on monitoring the signs, because if there's any situation where the vital signs are not good, then you have to reapply it back or stop the removal.
So you have to start from the lower end?
It has to start from the lower end. Yes. You remove the first segment, wait for 15 minutes, take the vital signs, remove the next segment, wait again 15 minutes, take the vital signs. So keep on monitoring any change. There's the rule of 20, Dr. which you can talk about. The rule of 20, that anything that goes above or below 20, then you don't. No. And that is the case I mentioned earlier, Homa Bay case. It was
they just removed
it because they wanted to prepare the lady to go to theater. They didn't know you can even use it in theater.
And what are the consequences of when you just remove everything once?
You just reverse the gains that you'd made.
Too fast.
Too fast.
BP drops.
It just drops, because you are like building up the volume from the lower extremity to come to the thoracic. So you are building it slowly, and it was, then now that's sudden, like
the pressure drops.
The pressure just drops like that.
What is the rule
and she
of
can
20?
Die actually.
And she can die as a result.
Yeah.
What is the rule of 20?
As you saw, the NAS garment has 6 compartments, the leg segments 1, 2, 3. So you start with the leg segments while applying, and also whilst removing, you also start with the leg segments. So before removing, you have to have a baseline vitals, blood pressure and pulse rate, and also the respiratory rate. So when you have your baseline, like let's say it was 120/80 and your pulse rate was 88, you remove section 1. Then you, after 15 minutes, you measure the vitals again. If the vitals have, if the blood pressure has dropped by 20, or the pulse rate has increased by 20, snap it back, reapply, and give it a chance, and re-examine. Are we having ongoing bleeding, or we need to bring in another transfuse? Do we need to transfuse? Do we need to increase the volume?
All right. Now, as we bring the conversation to a close, when it comes to just getting the awareness to this garment to the rest of the country, because it will go a long way in helping our women, and it is basic. Anybody can be able to make use of it. It doesn't have so much technicalities around it. When it comes to getting this garment to go across the country and help bring this mortality rates, what more do you feel needs to be done, especially from the Ministry of Health, our government, our county governments, given that health is now devolved?
So one thing which we've been started that conversation with, first of all, like the county, the leadership had to understand how it works and that acceptance, because eventually if they adopt it, they're able to actually purchase the garments and employ the trainings all over. At the national level, we also had some engagement, at least to have some awareness about the NAS garment. But the only hitch now is that, of course, as we are doing that, it is not embedded in the MOC curriculum as at yet, as we are speaking right now. So one thing is that we want to lobby and work very closely with the county and national governments if they're able to, have it in the MO curriculum, so that now anybody, anywhere, any county can actually use, because the guidelines are there. It's already approved by the Ministry of Health, World Health Organization. It's already something which is already approved. So if you have it in the curriculum, that is a one-stop. And then also if you can have it in the essential medical list items, so that now the KEMSA can actually purchase and
it's a basic.
It is a basic, because it's actually saving lives. So that kind of interaction, and of course more partners and health partners to actually take it up.
Come on board.
Come on board to
And maybe Joyce as well, what more do you feel we need to do to just try and encourage the uptake of such a basic tool that goes such a long way to save up to 100 lives that could otherwise be lost?
It's just to embrace what maybe Tanzania has done. They've already incorporated it in their emergency obstetric care training, and it's being disseminated across their country. So if already our country is doing the EMOB trainings, so it's just a matter of incorporating the NAS garment as part of management of the obstetric hemorrhage. It's already part of the PPH bundle, so it's just uptaking it.
Uptake is what also is still wanting. And of course, with all these partnerships coming on board, it will go a long way in just helping even encourage the uptake of such a garment. Even you at home could be able to purchase this in the event. It's better to be safe. You're prepared for this thing. We don't hope for them, but you don't hope for war. You just prepare for it. In the event that it does show up, you are ready. So we do hope from this conversation, the conversation does pick up, and we're able to embrace such basic garments that go such a long way to say up to 100 lives. They say one life lost is one too many. And especially for a lady who is giving birth, you are bringing forth life and you lose yours while at it. It is something that we need to help bring down and help protect our mothers. We were just having a discussion the other day about the fertility rates here in Kenya. It has gone down. In 1965, there was an average of 7 children. Fertility rate was at an average of 7 children every mother. At this time, it is an average of 3 children for every mother across the country. Why? some of us just want to be safe. You know, no lady wants to lose her life while trying to bring forth life. So let us go ahead and encourage such innovations that are going a long way in helping us all. We have been talking about maternal health care and how we can help avert maternal mortality, and we have been speaking with Dr. Joyce Wangari, who is a general practitioner at the Migori Referral Hospital. Thank you so much for being with us.
Thank you for having me.
And to the extreme left, we have Doreen Awino, who is the Community Health Systems Director at Luala Community Alliance. And thank you very much.
Thank you so
much. We absolutely appreciate you for making time to be with us this morning.
Thank you so much.
Now, Good Morning Kenya does continue. Remember, today is Health Tuesday. Up next, we want to run for you a feature on cancer awareness, just to let you know the situation on the ground. And much later, we are going to be having a conversation about female genital mutilation, the effects that come along with FGM. Stay tuned for that conversation. But for now, have a look at this feature about cancer here in Kenya. The hashtag is Good Morning Kenya. See you after the break.
Thank you.